Good afternoon, everyone. So thanks for the intro. My name is Dr. Ling. I'm the ENT surgeon. My focus is on rhinology and anterior skull base. I work at Glengarry and Hollywood, plus I'm at St Charles Government Hospital. I'm in the department there as well. So my talk today is on chronic ENT problems, but I focus more on the nose and the sinuses. And in particular, I was thinking about what I see in my practice and what I commonly see. So I'll talk about acute and chronic sinusitis, but I'll also cover non-allergic rhinitis, and invariably facial pain comes across through my office as well. So I'll try and cover that in the time allocated, but I'll put them a little bit over. And if I have time, I'll touch on chronic otalgia as well, because there's a bit of a crossover there as well. So sinusitis, as we know, is extremely common. About 30% of the population will have it at any one time, and about 15% of the population will get the cold, the common cold. It's very important as a presentation because there's a high patient burden, quality of life, and lost work hours. There's a cardinal signs of nasal obstruction, congestion, and discharge, and that includes rhinorrhea, post-nasal drip. And associated with that is facial pain and pressure or change in smell. And this is supported by the examination finding, which is generally on endoscopy of edema, mucopus polyps, or supported with CT findings. Now, acute is defined as anything that's 12 weeks. So that's one thing to actually explain to the patients, that it can take up to 3 months to recover from a sinusitis. And chronic is more than 12 weeks. There is a distinct subset of sinusitis called difficult to treat rhinosinusitis. And these are patients that have symptoms which last up to 12 months or more, despite adequate medical therapy, despite surgical management, despite steroid nasal sprays and saline washes, even having the odd course of oral steroids, and even the odd course of antibiotics. This is thankfully a very rare scenario. So our understanding of sinusitis has evolved over the last few decades. It used to be just sinusitis with and without polyps, and that was a very simplistic view of sinusitis. Sinusitis without polyps was felt to be related to an acute bacterial infection or some sort of infection which then failed to clear and then became chronic infection, and polyps was described as some sort of local allergy or systemic allergy. That's now no longer very sophisticated and led to a lot of patients not actually being treated adequately. We now know it's more of a syndrome with interaction between the environment, the patient, the immune system. And with that, now we have a better understanding of the mechanisms that lead to chronic sinusitis. The management actually doesn't really focus on the etiology. It's not possible for us to find the things that prevent sinusitis, but rather now we're more geared towards this sort of model of understanding of sinusitis, where we have the environment, whether it be multiple rounds of infections or exposure to organisms, the patient themselves, and there have been thoughts to look at the genome or the genetics of chronic sinusitis, but it's essentially impossible. There are known ones such as the cystic fibrosis gene, the CFTR, but it's those interactions which accumulate over time, which is why patients present in their 40s or 50s with sinusitis. At some point, it's finally had enough, and the mucosal barrier is penetrated, and it leads to an endotype of a characterized inflammation, and that leads to the clinical picture that we see as a phenotype. That hasn't formatted well, unfortunately. But basically, we know that the mucosa is colonized by fungi, viruses, and bacteria at birth. And in healthy individuals, the barrier is maintained, and there's tolerance and maintaining a healthy environment. In CRS, that barrier is penetrated, and then that leads to chronic inflammation. Now, the kind of inflammation that happens is broken down into the three types. And it's the way that the cytokines are described is actually very similar to the last talk about IBS. But basically, the one that I'm going to flag is the type 2, which is geared towards parasites. Type 1 is viruses, and type 3 are bacteria and fungi. The reason why that's important is because now we know more about the type 2 inflammation is most important, and interleukin 4, 5, and 13 are very important, and they're actually targets for some of the monoclonal antibodies. And they all recruit eosinophils, which is also why I flagged it, because we use that as a blood count for eligibility for some of the medications. This particular inflammation causes polyp formation, goblet cell hyperplasia and continued epithelial barrier abnormalities, which then leads to persistent problems in patients with chronic sinusitis. The picture there just shows that once the inflammation takes hold, you can see that the barrier is lost and then there's ongoing inflammation. So no longer is the model to do with any chronic bacterial infection, and it's not all about IgE. So now when we describe chronic sinusitis, we break it down into primary or secondary. Primary is basically the diseases of the lining itself, and we divide it into localized or diffuse. And diffuse doesn't mean pansinusitis. Diffuse just means it could be patchy and just different anatomical groups. And now we break it down to type 2 or non-type 2. So the classic example of a type 2 localized sinusitis is allergic fungal rhinosinusitis. And that's basically, you can see on the CT scan, there's a localized hyperdense material in the ethmoid sinus on the left, and with some results of opacification, which is the polyps. This is not an invasive fungal disease. This is an allergic condition. The reason why it's only on one side is because, quite simply on the right, the mucosal clearance mechanisms are still working. In the non-type 2 localized disease, this is more your classic patient who, for whatever reason, has a cold or isolated disease, and the sinus ostia is blocked. And from there being blocked, it fails to drain, and there's continued inflammation. These patients do very well with early surgery. In these kinds of patients, I put up the sphenoid because sphenoid sinusitis can give very odd symptoms. They can have postnasal drip or postnasal or cough, and then get these really bizarre vertex headaches, which can present. It's not always a guarantee, but sometimes you find these sort of problems. Now, in the diffuse condition, the classic one is allergic fungal rhinosinusitis, but this is the classic one where it's pansinusitis. There's hyperdense material in all the sinuses, polyposis, bony remodeling, and there's even bony erosion. And in the photographs, you can see there's the typical fungal mucin and the polyps. They still use the classification of CRS with polyps purely because that term is so widespread, but it's not an accurate term in the discussion of its etiology. And in some patients, they can have polyps, but it's not related to type 2 disease. And these are classically more older patients. They respond to corticosteroids, but not as significantly as type 2 patients. They can be smokers. But in this group of patients, and only in this group of patients, might I consider long-term macrolide therapy. But it's getting more selective now. In secondary CRS, there's a localized pathology causing the sinus disease. And again, in the localized one, it's really important to recognize that patients might have some dental problems. And you can see the arrow, there's a breach in the floor of the maxillary sinus. And so when patients have dental disease and have associated nasal symptoms, you have to be thinking, could there be odontogenic sinusitis? Most of the time, treating the teeth treats the sinuses, but on some occasions, the sinuses are already too inflamed. You can see the walls that are quite thickened. So isolated surgery, it does very well here to treat these patients. Fungal balls are more like foreign bodies. So this is not like the allergic conditions that we saw in the last slides. It's just basically a foreign body. For whatever reason, the clearance mechanisms have failed to clear the fungus, and it's grown within the sinuses themselves. It's basically a surgical problem. Once you eradicate it, the recurrence rate is pretty slim. There's no need for any oral antifungal therapy. And again, there's no danger of any invasive fungal disease. The one thing obviously we have to be wary of is tumors, neoplasms. They can obviously present like sinusitis. And on the CT scan, you can see what just looks like uniform opacification. But on the MRI scan, you can see there's a cerebriform form, which is consistent with lymphatic papilloma. So we always have to be on the lookout for those kind of problems. The diffuse secondary conditions are more related to mucosal abnormalities. So mechanical is more to do with the mucociliary clearance. And the classic example for that is cystic fibrosis. In these patients, they have thick, tenacious secretions. It's pretty much universal. Almost 100% of CF patients will have sinusitis, and almost all of them will have had one surgery, and most commonly in a pediatric setting. It's not uncommon for these patients to have multiple rounds of surgery. It's actually, I have a few double lung transplant patients, and their lungs are fine, but the main thing that actually causes them issues is their sinuses. The other ones include the vasculitises and then the immunodeficiencies, especially common variable immunodeficiency. Now, this is a fairly busy slide for acute rhinosinusitis, but basically it's a very common condition. And actually a lot of patients will self-care and present to the pharmacy and have simple analgesia, Panadol, anti-inflammatories, and the odd decongestant. I'm always very wary of decongestant sprays because invariably there's a high proportion of patients who abuse it. Antibiotics are really only indicated in acute bacterial rhinosinusitis, and that you can see in the breakout box there. Double worsening, fever, unilateral severe disease, or raised inflammatory markers. But pretty much for the most part, antibiotics aren't indicated for acute sinusitis. Maybe you can have it if someone's had a few episodes in a year. But for the most part, most of the studies have shown there's no improvement in symptoms, and if anything, most of the symptoms come back to the same after about 10 to 12 days. I will flag in patients who are having acute sinusitis, it's worth referring early. If you're finding that they're coming back to the practice, seeking antibiotics or seeking treatment, maybe it's time to refer. If you do refer, I would ask that a CT sinus scan is organised at the same time. It does actually save time for the patients. I would strongly discourage X-rays. X-rays of the nose have no use. And I'd also would say that any patient who comes from a dentist or who has had plain films is also not useful. They're better off having a CT sinus scan if they can. Chronic rhinosinusitis runs much the same. The only difference is the time course of symptoms. And once again, antibiotics are to be avoided. There is no role for antibiotics in chronic sinusitis. There's definitely a role for steroid nasal sprays and washes, and that's pretty much the two things you only need to push on the patients. The one thing I would really explain to the patients is these steroid nasal sprays take around 2 to 4 weeks to actually become active. So if they only use it intermittently or stop after a week, that's not appropriate medical therapy. I would say at least 1 to 2 months of continuous daily treatment is the true test for the use for steroid nasal sprays. And you'll find that actually a lot of patients do get better with that treatment alone. Now, failure of controlled treatment, then please go ahead and refer. But once again, the CT sinus scan is very useful. And just to round things off, from my perspective, when I manage the patient, nowadays, especially now that the paradigm has shifted, is now looking at what kind of information they have, and that's based on the assessment, the history, the risk factors, and actually just the blood tests as well now, which we can.
Mute.
Or is just mute all?
No, because then you'll get muted. And we don't want that. I did that before and everyone muted. Right. Cool, sorry.
All right. So in this situation, if patients have failed medical therapies, and in fairness, by the time most patients have actually come to see me, I don't make them go through everything again just with me. I think by that time, a lot of patients have waited quite some time for their symptoms. So I will offer, we'll talk about surgical management. And again, the non-type 2 patients are the one where I talk about long-term macrolide therapies. But I will always stress that it's actually a medical problem first. So I don't know if someone's actually got their symptom under control with steroid nasal sprays, there's no surgery indicated. They just have to understand that it's just like asthma. They have to be on the spray lifelong. And that for some patients then puts it into perspective for them, or they just ignore me, so it depends. All right, so management, as I said, medical management is the mainstay. I would go straight to the second generation, such as memetazone and fluticasone. And I think combination sprays are very, very valid. I think they're very useful. The only downside is their cost. But as I said, the main thing to stress is to use it every day. Saline washes absolutely are very useful. And in some patients, saline washes alone I've seen patients just do very well on washes. And it can be a bit challenging for patients who haven't had surgery. It makes them feel like they're drowning. And also they will talk about how the water keeps coming out when they turn their heads in certain ways. That's actually normal. As I said, antibiotics, not really indicated, but if patients do have typical symptoms, they're very severe or they're very unwell, then of course they should have it. I would go straight for mention duophor. I wouldn't bother with amoxicillin or Keflex. I mention duophor. I must admit, I give clindamycin. Once patients come to me, I know they've already tried lots of other things, and clindamycin I find is very effective. I culture when I can, and as I said, clarithromycin I use it long term. Doxycycline has no use, shouldn't be prescribed, doesn't have any evidence. I think it was described before for long-term antibiotics for polyps. That's no longer evidence. So doxycycline shouldn't be used. It's not effective enough for the sinuses. Sinus surgery. I offer it in patients who have poorly controlled symptoms. That's as a very basic statement. But basically, anyone who has a symptom score more than 5 out of 10, so moderately severe, who start to control, it's very safe. There are complication rates that used to be described very, very slim now. Packing is dissolvable. There's no gauze. The performed as a day case, so patients go home the same day. Pain minimal. The most of the patients will feel is a block sensation like a cold. I do explain that the goal of the surgery is to clear out any disease, polyps and infection, but to also open the sinuses up and I correct any anatomical abnormalities. But the main thing I explain to them, this is for the topical therapies. This is not going to cure you of your problem, but there are very good studies to show that there's good improvements in short-term results. This is the patient with allergic fungal rhinosinusitis. I saw just now that what was sucking out was that thick mucin. That's typical of eosinophilic sort of rich disease, and that's the debrider. That's how we sort of do the surgery. And this is now the quality of the images that we can actually get. We have 4K images, navigation, so it's a lot safer than it even was, say, 10, 15 years ago. Okay. Now, of course, I have to talk about biologics because this is what's come out this year. So these monoclonal antibodies have been around for asthma, for other conditions like dermatitis. But as of this year, PBS has approved mepolizumab, which is Nucala, for the use in nasal polyps. Now, of course, as I mentioned previously, the Th2 endotype is now known, and now we have these multiple targets for the inflammatory pathway. So mepolizumab and Nucala is IL-5, dupilumab is IL-4 and IL-13, and omalizumab is an anti-IgE, and that's one's used for asthma. It's very good. There's a high response rate. It does reduce symptom scores. It does reduce polyp size. It does reduce the need for further surgery. The downside, it's monthly injections and it's lifelong. We don't know how to end this or what the exit plan is. Essentially lifelong jab. It's expensive. Before it was on PBS, which is now $30, it's $1,600 a month. So the criteria is strict. Generally speaking, it's patients who have had surgery before. They need to have a high eosinophil count. They need to have large polyps. They need to have high symptoms. There are odd patients who probably aren't fit for surgery, but then you need to have 2 ENTs sign off on it. But basically, it is available. I've already prescribed it a few times now already. Obviously, the PBS has to put them on this because for $1,600 a month for one patient, there's some important health economics related to this. Now, non-allergic rhinitis. Now, non-allergic rhinitis, I see a lot of this. All the rhinitises cross over. Chronic sinusitis, non-allergic rhinitis, allergic rhinitis. All patients present the same way. A runny nose, blocked nose, sneezing and itching. It's really hard to figure out what exactly is going on. But the thing about non-allergic rhinitis, and for me, this is my little passion piece, I guess. I think it's a very, very weird symptom because you can pretty much diagnose this within 30 seconds if you ask the patient what the problem is. The thing I always ask them is the very one question: does your nose run in cold air and dry air? Yes, then you have non-allergic rhinitis, and that pretty much sets things up. Some patients talk about the sensitivity in the nose, like it's itchy, or when I go into a certain place, my nose, they always point to here. For me, that's also a sign of the irritation. It's very common. 30% of the population have it. Almost half of the patients are idiopathic, which means there's no underlying cause. If you have allergic rhinitis, then that really makes it more confusing, but then we just call it mixed rhinitis. Now, as a term, non-allergic rhinitis, it's actually like just an umbrella term. And it breaks down into these two basic pathways: inflammatory, so it's cellular mediated, and neurogenic. And the neurogenic one is actually really important. So we know that the trigeminal nerve, with branches from the parasympathetic supply the sinus mucosa. So most non-allergic rhinitis is an imbalance between the parasympathetic supply to the nose, which causes mucus and rhinorrhea, the sympathetic supply, which involves vascular tone, so that's congestion and swelling, and the nociceptive fibers of the trigeminal nerve, so the irritation, the itchiness, and the sneezing. But there's a lot of crossover. As you can see, occupational rhinitis sits in both camps. Rhinorrhea of the elderly is fairly much is your typical patient who's elderly, who has a runny nose and nothing else going on. They also just have non-allergic rhinitis. Rhinitis medicamentosa is a very important one. As I mentioned, because decongestant sprays are just available over the counter, a lot of patients just abuse it. And once they're in that trap, they really kind of get themselves out of it. I found this a very useful slide, because this is how you can just break down what the causes of the rhinitis is. And the first question is, if you're over 65 with a runny nose, you essentially have rhinorrhea of the elderly, which is better than the old term which I used to use was elderly rhinitis or senile rhinitis. So that's basically, that pretty much, as long as you rule out all the other conditions, is pretty much the reason for why a lot of patients just go, I have runny nose. And then occupational, I asked the question, does your symptoms get better when you go on holiday? Yes, it's big at work. Just touched on the decongestant ones, and you can see each one: hormonal, drug-induced, gustatory. Now, gustatory isn't just always with one spicy food; it's with any food. There's some sort of aberration in the pathway, but I've had a few patients who just tell me every time I go out to eat, it's very embarrassing. My nose just starts to run, and for some patients, it means it can be very annoying. And these are the things. Rhinitis has never killed anybody, but that's why no one really tries very hard to sort of do anything about it. Now, on the right, you can see that that's the breakdown of the. This was from a Dutch survey. They recognise that their medicamentosa rate's probably a bit higher than normal. Normally, it's about 10%, but you can see, broadly speaking, idiopathic has the highest group, and this is the general breakdown of all the other ones. Now, for this, sprays are the main treatment, and go straight to the combination spray. I wouldn't bother with the single agent steroid sprays. So basically, any patient that comes to you with a runny nose, just go straight to the combination spray, because you'll cover most of the things. So we don't know why it works, but it does. So the combination of the steroid and the antihistamine seems to work best. Now, ipratropium bromide is an acetylcholine competitor, and is very good at basically treating the rhinorrhea. It used to be available commercially, which was great, it was cheap. Now you can only make it as a compounded spray, which I still give to patients. Basically, I just use Genie and I just put atropine nasal spray and just add the word please compound or compounding pharmacy. The pharmacies know how to make it. Unfortunately, it does drive the price up. I've seen price vary from $40 to $80, depending on where they get it or who they get it from. There's no role for antibiotics.
So just on that, I had another ENT recommend you get the atropine asthma popper, and you just have a piece of paper or cardboard over the top with a hole punched in it, and that narrows it enough to actually use an asthma popper on that is.
Well, I must admit, we've ended up using a Queensland compounding pharmacy, customized compound, and they've been heavily, they know in our ENT space, a lot of our stuff has to be compounded because COVID, a lot of companies just stopped making it. So $40 is for the Queensland company. But yeah, look at that. There is no role for antibiotics, and definitely decongestant sprays, if they're on it, you've got to try and get them off it. It's very, very hard. So when I do try and get them off it, I tell them it's going to be worse. It's going to be bad for a while. I'll even start some oral steroids for about a week or so, get them onto Reatris or something similar twice a day, and just tell them to put up with it, because I have seen complications from it. I have seen septal perforations from overuse of decongestant sprays. Now, imaging is going to be useful because you have to, consider all the underlying problems, such as polyps and neoplasm. But you have to be cautious with the results of this. About 30% of the population will have some sort of mucosal thickening or mucus retention system that actually has no bearing clinical relevance. But as we know, our patients, once they find a symptom and find a positive finding, they can't break the two links, and then they're convinced that they have an infection or they're convinced they have polyps. Now, the treatment failure rate is about 20%. So 1 in 5 won't get any relief of the symptoms. Whether they do anything more about it depends on how severe they think it is. For obstructive symptoms, it's fairly straightforward. We can offer septoplasty and turbinate surgery, and that would be useful. For the actual rhinorrhea symptoms, and this is very important as well. So patients who come purely for rhinorrhea, if their CT sinus scan says turbinate, says septal deviation, addressing the obstructive symptom will have no bearing on rhinorrhea. I make it very clear. If your problem is to do with rhinorrhea, a septoplasty is not going to fix this. But a videoneurectomy can. Pretty good success rate. In my practice, it's higher because I'm much more selective. Basically, these patients will say they live with a box of tissues all the time. So I'll say, you're going to trade your box of tissues for a dry eye. So basically, box of tissues for eye drops. And that basically, if some patients can't tolerate the idea of a dry eye, then unfortunately that's the end of management, and they have to live with their runny nose. But a videoneurectomy focus is done through sinus surgery, and it's all still endoscopic. And basically, the video nerve passes on the floor of the sphenoid sinus, runs behind the maxillary sinus into the pterygopartum fossa. It literally just sits behind the nose. It's relatively straightforward to access. It doesn't require too much dissection. But the reason why there's a dry eye is because the nerve fibers also supply the lacrimal gland. Now, surprisingly, after about 6 months, most patients do okay, and they don't need to use the eye drop. And saying that, by the time they've been doing it, it becomes routine for them, and then they don't mind just doing the eye drop in the morning. Risks are fairly low. It's very rare to have any paresthesia or V2, and it's very rare to have persistent dry eye. Now, I thought I'd cover facial pain. Now, I don't pretend to be an expert in headache or facial pain or any neurology, but we do see a lot of patients with facial pain. And the word sinus headache, I honestly don't know that term. But basically, patients will, and nowadays, go on the internet, look for the condition, go to a pharmacist, go to a dentist, go to your optometrist, and then their headache is called a sinus headache. And the reality is that in some surveys, up to 90% of sinus headache is actually migraine, and they don't meet any criteria for any sinusitis. There are other non-sinusitis but nose-related headache problems. And of course, it's actually very challenging because some patients are convinced that their headache is related to the sinuses, and trying to say otherwise doesn't always go well. I always involve a pain specialist. Basically, I'll do what I can, but then exclude any underlying inflammation. But I thought I'd still present some stuff today. For rhinogenic causes, you can have sinus barotrauma, so patients who fly or dive who probably have facial pressure or pain. Mucosal contact point headache is a controversial one amongst ENTs. Basically, the concept is that if there's two surfaces in the nose that shouldn't be touching, it may cause headache. I think that one, you would offer surgery if a patient's exhausted every medical treatment possible. And then recurrent acute sinusitis can have these sort of strange headaches. And it's difficult because they actually don't have any, the CT findings are fairly normal, or the examinations are fairly normal. Now, non-rhinogenic headaches is a bit of a grab bag term, but the common things to exclude is TMJ disorders, teeth disorders, and the migraine tension type headaches, and the trigeminal autonomic pathologies. Some of the things that can be associated with these kinds of headaches are the more stranger symptoms, such as whether pressure changes, cellular variation, nausea and vomiting, worsening with activity. Severe pain should point you away from the sinuses. Sinusitis doesn't cause that much pain. Those patients with allergic fungal sinusitis or polyps coming out their nose don't ever report pain. So the more intense the pain, I would just start thinking perhaps it's not going to be the sinuses as an underlying cause. Of course, photophobia, and balance type symptoms. Now, attention type headache can be mistaken for sinusitis because of the description. Band-like pressure around the frontal and temporal region can also be mistaken for TMJ disorder, and the symptoms can also overlap with migraine. There's also a new description of mid-face facial pressure pain, which also has nasal symptoms, and you can see how patients can easily mistake these symptoms for sinus disease. But commonly they'll have normal examination and normal CT scan. Basically, I ask patients if they're feeling stressed, and some of them are, and sometimes I'll start amitriptyline or nortriptyline for these patients, low dose, something like 10, 25 milligrams. Now, as I mentioned, there is a lot of autonomic supply that travels with the trigeminal nerve. So there's going to be a lot of autonomic activation with some of these headache syndromes. About 40% of migraine patients will have some form of nasal symptom. The classic, unfortunately, it hasn't projected well. I'm not sure what happened there. This is not how I formatted the slide. You see the bottom part, can't see it. But basically, this trigeminal autonomic catharsia, the main groups are cluster headaches, paroxysmal hemicrania, and hemicrania continua. There is a high rate of secondary pathologies in these patients, so it's worthwhile getting some form of neuroimaging. And I found this slide, and it was very useful because you can see how, with the descriptions of pain that these patients have, how it's very easy for them to mistake this for sinusitis. But what I take away from this is any pain that starts to radiate away from the face, especially towards occiput, shoulder, neck, and arm, or mandible region, again, you start thinking non-monogenic headaches. And about 30% of migraine can be bilateral as well. So cluster headache is the prototypical version of a trigeminal cephalic neuralgia. There's a lot of active autonomic activation, hot, poker, stabbing eye symptoms in younger patients, male predominance. This diagnosis can be delayed. In some studies, about a third of patients see the ENT first. These sort of conditions need to see a headache specialist. This involves oxygen, sumatriptan, and rapidol for some patients. Paroxysmal hemicrania. As you go along the spectrum, the autonomic symptoms become a bit less, but the actual headache, the description of the headaches become a bit less intense and less frequent and more long-lasting. And in this condition, there's more temporal, periauricular, and maxillary tenderness, and then it can radiate to the arm, shoulder, and neck. Indomethacin is pretty much the response. If you start at 150 milligrams, if the headaches are gone, that's the diagnosis made. So it's so much so that that's actually one of the criteria for the diagnosis. And as we move on to hemicrania continua, this would be what patients might mistake as a sinusitis or even migraine. These more continuous pressure type headaches, but with still some autonomic symptoms, but not as pronounced as a cluster headache. But again, indomethacin here is very useful. And of course, classic migraine with aura or without aura, headache lasting more than 4 hours, unilateral in nature and throbbing. But as I said, 30% can be bilateral with photophobia. There are vestibular migraine associations as well. And there's an orofacial pain group. And they've also described orofacial migraine, where there's more V2 mid-face involvement as well. This I thought was a very useful slide because basically any headache lasting more than 4 hours, I think it's not going to be the sinuses anymore. We're thinking more migraine and headache type syndromes. But you can see anything less than 2 minutes, it's a trigeminal neuralgia. What I didn't talk about was short lasting, unilateral. That's the snucted one. It's a very specific form of the trigeminal catharsias, and then cluster headaches in there as well. So monogenic headache, I'll just go through it very briefly because it's more of an anatomical issue. Basically, this is a septal spur, and so basically the idea is that if there is mucosal contact, then perhaps this is where the cause of the headache is. I think, again, that's got to be taken in context of the patient broadly, and you've excluded all the other causes. But there are other things such as a concha villosa, where basically there's a pneumatization of the middle turbinate, and that's just basically too large. And so they can cause mucosal contact issues, but it also can cause a drainage outlet issue with acute sinusitis. And of course, Have to be aware of other causes, odontogenic, mucoceles. Mucoceles basically like a mucosal cyst, they just slowly expands. And of course, sinonasal masses, neoplasm, always have to be aware of those. So for me, my approach is basically, not only now do I just take my full history also now covers a bit of the headaches as well. So the nature of the headache, the pattern, the patient, any provoking factors, and the family history of headache is also very useful as well. And then my examination, I'm looking at the nasal cavity, making sure there's no obvious inflammation or polyps. A CT scan can be useful. Some studies have even said if a patient has a normal CT sinus scan, it's going to be a migraine. 90% of the time, it's going to be a migraine. So you could almost just start a migraine therapy, and if that settles it, then it stops all the steroid nasal sprays, washes, and antibiotics, and it actually starts to get the diagnosis clearer. Endomethacin can be started if you're thinking trigeminal, those of that category of headaches. Low dose amitriptyline, I do start, but basically I will refer to a pain specialist. Pain science in Joondalup, Dr. Raj Menon, he does a lot of this sort of pain, sort of the headache sort of stuff as well, and the interventions there. Chronic arthalgia, I thought I'd cover it because there's a lot of it. So I thought I'd try and talk about it here today. Basically, the nerve supply of the ear is supplied by C2 and C3, so cervical nerves, and cranial nerves 7, 9, and 10. So C2 to the top, C3 at the bottom, and 9 and 10 towards the meatus and in the middle, which is why there's so much preferred pain to this region. Primary arthalgia is any disease of the ear itself, so otitis externa, otitis media. Wax impaction. A bit of wax doesn't cause any pathology. Severe wax impaction is severe wax impaction. You cannot see the drum. So it's very, for me, in my opinion, it's very rare for wax to actually cause any pain. It's far more common for primary arthalgia to be in children than in adults. But the one patient to be aware of is the immunosuppressed, diabetic, or elderly patient with severe arthalgia with a history of otitis externa. There's always a risk of skull-based osteomyelitis. And these patients will practically have nighttime pain. The pain is bad at night. That needs a tertiary referral. Now, secondary arthalgia is when the ear looks normal or when you can't pinpoint the cause of the pain from the ear. So we have to exclude the upper auditory tract because of 7, 9, and 10. But there's also cervical spine and TMJ dysfunction. Always have to be aware of the sinister causes. The shorter the time, the more likely it's going to be primary. But the longer the time the patient has pain, the more likely it's going to be secondary. So, of course, with the ear history, discharge, hearing loss, but also pruritus, itchiness of the ear is very common. Dermatitis or chronic otitis externa is very, very common. Of course, there's the red flags that you have to look for: dysphagia, dysphonia, pain on swallowing, weight loss, hemoptysis, smoking history, but also other histories, dental and jaw issues, bruxism, neck issues, sinonasal symptoms, and of course stress as well. On examination, looking for pyrolens, foreign bodies of blood. If you can't see the drum and you see pyrolens, but it hurts to put the otoscope in, it's almost going to certainly be otitis externa. And then oral cavity examination. So I examine perirectally around the TMJ, angular mandible towards the neck. And generally, pain around here is actually more TMJ, especially if you press hard on the zygote or under the angular mandible. That's going to be more likely TMJ and myofascial tendons. And tenderness around the back of the neck, mastoid tip or trapezius, also tends to be more neck and not really the ear. And then, of course, I'll do a scope, making sure there's no pathologies in the airways, like tonsil masses, basic tongue masses, those kinds of things. Basically, what to do next when a patient with a sore ear that you can't find a cause. If there's any hearing issues, get an audiogram. But the next test to do is a CT temporal bone scan with neck and without a TMJ. That pretty much picks up the majority of the pathologies if you're going to find any. It's very good. CT neck will exclude your tonsil SECs and any underlying sinister causes. We'll pick up the rare things like Eagle syndrome, which is a bit like the glossopharyngeal neuralgia. The TMJ part will cover the TMJ arthropathies. And the best thing is when all that's normal, it's actually pretty reassuring. A normal scan pretty much rules out any underlying pathology, and it might be stress related or neck related, musculoskeletal related. If there's any red flags early, refer early and scan early. That's what I would definitely suggest. if there's any TMJ dysfunction, especially with bilateral atalalgia. Bilateral atalalgia is almost always secondary, and it's almost always TMJ dysfunction. So that one you refer to oral med. I know that TMJ disorders can give you ear symptoms as well, blocked ear symptoms, tinnitus, and vertigo. It can be hard to pull apart. But basically, if a patient has any jaw or inflated symptoms, it's worth an early referral. And of course, any of the complaints should be received by a physiotherapist in the first instance, and then taken there accordingly. Any questions?
Very much, Dr. Ling. We'll just have a quick check, see if there are any questions. There's one. There is some chat. So.
So how do you manage children with non-allergic, non-infective rhinosinusitis and sinusitis? I think in those situations, it depends on the age. So for the most part, a lot of nasal or sinusitis rhinitis in children, it depends on the age. So any child under 2 or 3, there's this concept that because of the fact that they're small, they're going to have a rhinitis. So simple things, just such as saline spray. If there's any suggestion of any hyperactivity, you can start Nasonex as young as 2. It is annoying because you have to write a script, otherwise the pharmacist won't give it. But you can give those. Now, as the child gets older, you can, if the symptoms are still persistent, you can certainly try adenoidectomy. So adenoidectomy treats pediatric sinusitis about 50% of the time, so very, very effective. And the terminal reduction surgery is very, very useful as well. And there are some patients who still would need Nasonex moving forward, but those simple measures, terminal reduction surgery and adenoidectomy, actually addresses a lot of nasal complaints from kids.
Most of the chronic sinusitis patients are associated with allergies, high allergies to grass or dust. Do you recommend desensitization or see the immunologist, to do the treatment?
Absolutely.
So is there any age limit? Because
Start early because there's a concept called the atopic cascade. So it starts with eczema, allergic rhinitis, asthma, and if you catch it early, you stop that march. So early. And I mean the problem with immunotherapy, it just depends. So I'm happy to prescribe Active and Ololev, which is the sublingual immunotherapy for those which is available. Downside, it's $100 a month. It has to be done every day, and in fairness, there's different models behind how some immunologists do single agent, they just do the one agent. Some do multiple agents. At the end of the day, I just like to work with immunologists that in that space a bit more. But if it's a single agent house dust mite or single agent grass pollen, I'll talk about it. It's funny. Not a lot of patients want to take a tablet once a day for $400 a month, but they might rather have a jab once a month by the immunologist, as long as they get something. And with that is a discussion of allergies. They need to be on all those treatments, and it's lifelong.